right, good morning. Brad, are you there?
I
Brad,
am.
can you hear me?
Yes, I can hear you. Is my mic on?
Yes, we can hear you. All right, are you
great.
ready to go? The floor is yours.
Okay, well, I am. Great, thank you guys. So, welcome to New York. I'm sure the weather there is a little bit better. And we are now the home of not only the Enterprise, the space shuttle, but also Tim Tebow. So, we're very excited to have you with us.
Congratulations,
I want to thank you guys all
suppose.
for... right, we're all going to be Tebowing after the case, so I hope you stick around for that. Just want to thank everybody for having me. Welcome to South Nassau. We're going to go over the x-rays here. We have a 63-year-old female who is fairly active. And let's take a look at the x-rays here. My standard x-rays are, an AP of the pelvis, AP of the hip, and my false lateral profile on the, all the way on the left here. She's got a bit of an inferior osteophyte, nothing too drastic, but I template before each case. I mean, I have the ability to do digital, but I always make the point to template right before the case, because if I templated 2 days ago, I won't be familiar with what I templated. So just to show you how I do it, I make a dot at each, at the bottom of the teardrop on each side. That gives me a true horizontal. And then I make a 45-degree angle here, just to give me an idea of where my, for my cup placement. I make a dot at the top of the lesser troch. I'm not sure you can make that out. And also on the most medial aspect of the lesser troch. This dot in the center is the center of rotation of the femoral head on both sides. And I'll measure the lesser troch to center on each side, which is the top of the lesser troch to the center of rotation of the femoral head. I call that the LTC. And I'll show you how I do that intraoperatively as well. I measure both sides. I have a value of 42. I template my cup and my stem as well, and I get an idea of where my neck cut is going to be. Templating with the SMF can sometimes be difficult because, again, it's a little bit of a beefier stem in the anterior posterior plane, so sometimes we get a little bit more fixation and held up in that plane, and sometimes on the AP radiograph it doesn't correlate very well. So we're going to get started over here.
So do you find that
I've mapped out...
Do you find that your templating is usually oversizing or undersizing for the SMF?
Yeah, it's typically oversizing because, again, it may look like you're going to get in a 3 or a 4 stem on the AP, but sometimes in that plane we'll get held up in an anterior-posterior direction.
I agree.
So we may wind up going with a 1 or a 2.
I agree. I've found that as well, usually under by 1.
Right. That's what we've been finding here. So I've just mapped this out. I like to be on the posterior third of the femur. The larger the patient, the more cushion. Further back, I'll bring the incision, and about half and half above the tip of the greater choke. I am not a minimally invasive guy. I'm going to make this just a touch more generous than I normally do, just so we can see a little bit better. Okay, so we're going to get started.
What sort of anesthesia are you using?
It's a good question. Our standard of care here is to use a spinal anesthesia. I like regional. I tell my patients it really decreases their risk of bleeding, infection, blood clot in the leg, and it decreases the time of the surgery. Now I'm on the posterior third of the femur here, and I'm just going to go ahead and test the fascia. And it's a little on the thin side, so I'm probably a little anterior. I like to be just about a centimeter in front of the maximus tendon, and I can feel it here. I'm pretty good, so now I'm going to go ahead and take the rest of it.
Is the posterior approach your standard approach for all hips or just for SMF?
No, the posterior approach is my standard approach.
Have you had to make any modifications?
A couple of moist laps, please.
Have you had to make any modifications in your approach to use this SMF?
I haven't, and I'm a flat taper stem user. I went originally from the Trilock to the Anthology, and now I'm using the SMF, and I haven't had to modify my approach at all.
Was it a pretty easy transition for you to move from the flat tapers over to the SMF? Yeah,
it was, and it's actually a pretty good It's actually an easy transition for both. I mean, I think we're seeing kind of the best of both worlds here, where it's easy for a, just bring the Mayo stand in, where it's easy for a flat taper stem guy and a metaphyseal filling type of surgeon to go. It's kind of the best of both worlds as far as the design. So here we have, I have this laid out. You can see the max tendon here, and I take usually about half of this down, and I'll feel the release here. And I think that that just releases some of the tension on the sciatic nerve, so that when we bring her up into 90 degrees of rotation, there'll be less pressure on that nerve, so theoretically a lower incidence of a sciatic nerve palsy. And now I just bring everything down in one sleeve. I don't take down the rotator separately. And here we have the lesser troch here. You guys can see okay?
Yep, we can see fine, thanks. And how far up do you take that capsular sleeve? Do you go up to the piriformis, behind it, around it? How do you hold on to the piriformis?
Right, good. I go just above the piriformis when I take it down, and I'll show you that in just a second. And at this point, I typically will expose that piriformis. There's a little bit of fascia right there, and I'm just going to cut that. Okay, Homan. Okay, Emily, you hold that. It's more of a push down and a pull back, okay? So if we could see that here, I'm looking at the piriformis right there. Let's see if we can just show that just a little bit better. So the piriformis is running right here. And what I'll do is I'll take down the capsule, and I'll go right down through the capsule, just above the piriformis, and I'll go ahead and follow that all the way up as far as I can get on this side. And I have the leg in internal rotation, putting a little tension on the capsule. And I'll start taking that capsule down, and we'll start seeing it release a little bit. I'll bend this tip just a touch to get under there so I don't cut the capsule short, so I have a good repair at the end. And again, I'm just taking this all down in one sleeve, and the piriformis stays attached. I'll show you after we do the cup. I'm going to go ahead and put a couple of tag sutures in and just suck right there.
Do you take any
precautions? Around this corner.
Do you take any precautions for any of the bleeders in the back, or do you just hit them as you go?
I kind of just hit them as I go here. She's a little stuck down to the femoral neck here, but she seems to be cooperating now. There we go.
And it looks like you're just going ahead and stripping that off the neck, all the way from the greater troch down around the neck.
Correct. That's correct. And you can see here we have my bovie is in between the femoral head and the socket. So I've taken the capsule down this way, and I'm taking the synovium off of the neck. I'm coming a little bit more inferior. And a little bleeder here. Again, now I use the lap just to give me a little bit of traction. We can see the capsule laid out here. Here's the top corner of it. And down here, I'm just going to arbitrarily make a radial cut to give me my bottom corner. Okay, let me have an O Frank, please.
And where is that retractor going?
Okay, so yeah, this is just below the ischium. This is just in the infracotyloid groove. And can I have 2 cokers, please? Just to show everybody the 2 corners of the capsule that I've made. No, I have my 2 corners laid out here, and that's where I'll put my tag sutures, and I'll grab the piriformis with that in just a little bit. I just wanted to point that out. Now I'm going to show you how I do my leg length. So this is a Steinman pin, and right here, right where I made my radial cut, as I push it superiorly, I start touching the ischium. And so I'm going to find the crotch between the ischium and the acetabulum. That's the infracotyloid groove. And I'll just let it kind of fall in. And then I'll put the pin straight up and down. Now let's bring this down, please.
So you find that more posteriorly rather than inferiorly around the ischium?
Correct. Correct. It's right where the ischium meets the acetabulum. So I look and make sure that we're straight up and down facing the ceiling, and I'll make my little mark here.
What position is the leg in when you make this mark?
The position is not as important because we just need to recreate it. So if we can pan out just a little bit, you'll see I'm going to mark the position of the leg so I can reproduce that after we reduce the trial hip. And then I'll mark the drapes as well.
So do you use any other measure for leg length? Do you check the knee and the heel? You check shuck pre-op
I
before
don't.
you dislocate?
In fact, I have it's very difficult to do with how I set it up. I have a mattress that's right here so I can have a flat surface so the leg is not everywhere. But I use this and I find it very reliable. Let me have this, please. So now I'm going to mark my LTC, which is my lesser troch to center of rotation of the head. So I'll come down to center of the neck and I'll guess at about what the center of rotation is here. So I have it on the x-ray, and now I'm going to confirm the magnification with my ruler, and I lay this right on top of the psoas tendon. And I'll bring that up, and it looks like it's about 46. You guys can see that pretty well?
Yeah, we see what type of ruler you're using. There you go.
And I'll also take a look at I don't generally measure the neck for the neck cut. I don't generally measure for the neck cut. I template it on the x-ray, and what I do here is make a rough cut. So I don't have the saw, please?
Can you define that a little more? What do you mean you don't measure for the neck cut?
Yeah. Well, I make a rough cut, and then as I find the right position of the stem, I'll go ahead and put the calcar planer and bring it down to the correct length. But I'm not as concerned right now about the neck length. I'm concerned with not leaving it too short. So I'll leave a little extra here.
But you did template a neck cut on your x-rays, correct? So you have some idea about where that cut should be.
Correct. Correct. And I'm not making a point to be too exact at this point, because I'll wind up bringing it down. Now, this is a good time to check the anterior neck for osteophytes, and I'll get them now just because they're a little easier to access at this point, but she happens to not have any, so we're in good shape. So I'm going to go ahead and expose the cup. And I separate this into 4 quadrants, so I put in 4 retractors. So this is my C retractor, the Ranawat retractor, and I'll put that in at about the 1 or 2 o'clock position to start, and then O franc below, in that same position that I had it in before. I'll put a Steinman pin to retract the abductors here. And then, yep. Now I put a bent Holman at about the 9 o'clock position.
How many assistants do you have with you in the operating room?
I have one assistant in front on the other side of me, and then I have another assistant above. So usually we have 2. 1, 2. Now I'll tilt the table back, and we're not rich enough here to have an automatic one, so I'm cranking it by foot. And now this is an important part of the exposure. So if you guys can see right here, we have the reflected head of the rectus coming in at about the 12 o'clock position. And if we put just a little pressure on the C retractor, and then I'll take down that tension, you'll see the femoral slide forward very nicely and give us great exposure. So now we'll go ahead and replace this and put that in the same spot. And it's going to kind of go over the AIIS. And I'm just going to move this out of the way. And I think we have pretty good access to the cup here. So I'm just going to clean this cup up a little bit, get rid of the labrum, which seems to be ossified.
So about how far back is this patient right now?
I'm sorry?
About how far posteriorly? You said you...
Yeah, I've tilted the table back about 30 degrees or so. Now I'm just taking out the soft tissue from the fossa. I start at the transverse acetabular ligament when I do that, so I get the artery.
So you take down the transverse ligament now?
I don't take it down, but when I'm taking out the soft tissue from the pulvinar, I'll start at the ligament and work my way up so that we can get that bleeder under the ligament. And I'm just going to replace this. Bonjour. Sorry, my head's going to be in the way for a second here.
Do you make a point to try and find that medial wall and expose that, remove any osteophytes every time?
I do, of course, yeah, and we're going to get there in a second. I just replaced the retractor. I'm putting it right behind that transverse acetabular ligament, so I really have good exposure here. Now, can I have the elevator, please? So she's got a bit of an inferior osteophyte here and also an anterior osteophyte. So the key with, and there's a little bit of a natural demarcation here between the true end of the anterior wall and the osteophyte. Not everybody has that, that delineation, but you know, what I do is I put the elevator over the front of the acetabulum and I'll feel the pubis here. And generally when you're flush with the pubis, you're inside the true anterior wall. And we'll go ahead and remove this, the anterior osteophyte after I ream and get my cup in. So I'm seeing here, and that's another way that I judge my version as well. I want to be inside the anterior wall, flush with the pubis. Generally, you'll be about 15 to 20 degrees aneverted. Okay, let me start with a small reamer. So I've templated to a 52. So I generally start 9 to 11 millimeters below that. And we'll go ahead and try to take out the medial osteophyte here. We want to medialize it so we can get good coverage of our cup, decrease the ground reaction force. Okay, getting there.
Did you measure the femoral head at all to help determine which reamer you're going to start with, or just always go several sizes under your templated size?
Yeah, I don't measure the femoral head for that. I know a lot of people do. I typically just start about 9 or 11 millimeters under.
And I see you're using a straight reamer handle with non-cutout reamers. Is that your standard?
Correct, yeah. I think we get good enough exposure that we're able to go ahead and use the straight reamer without too much of a problem. So now we're down to the medial wall here. And we've reamed evenly anteriorly and posteriorly. So now I'm going to go ahead and bring it down and start reaming in a little bit of a better position.
How do you determine what position you're reaming in now? What are your landmarks?
Right, so anteriorly, I like to be flush with the pubis. And as far as my closure, what I'm doing is looking at the x-ray. And that line that we have on the x-ray, and I'll take the elevator, it pretty much intersected with the superior part of the acetabulum. So when the trial cup or the real cup is in 45 degrees, it should be flush with the superior part of the acetabulum. It's also important to note that on a right hip, that's going to be at the 1 o'clock position, not at the 12 o'clock. It's going to be at the 1 o'clock because the pelvis is tilted 15 degrees forward. All right, let's go up.
So it looks like you were just reaming a little bit of the rim right there.
Yeah, I'm reaming the rim. I'm just trying to get wider here. I think I'm deep enough, so I'm not really pushing. I'm just getting the I'm getting the anterior and posterior walls opened up a little bit. And now I'm getting the rim here, posterior inferiorly, it's getting held up just a touch. And we're at 51. I think we're looking pretty good. Let's try a 52 trial.
So you ream to 51 and you're putting in the 52 trial, correct?
Correct. I always under-ream by 1. If they're very osteopenic, I will consider under-reaming by 2.
So it looks like you're
now
hitting...
I have my cup in. Go ahead.
No, go ahead.
Elevate. Okay. So I have my cup in. I see the anterior osteophyte here. I'm going to put my elevator over and touch the pubis, and it looks like I'm just inside the pubis, so I think my anteversion is good. I'm inside the bone anteriorly and posteriorly, and at the 1 o'clock position, I'm just about flush with the cup. If just a little bit is exposed, then I'm a little bit more closed in the 45 degrees. So I'm pretty happy with this. I have a good peripheral fit. I'm going to go with a solid cup here, which I tend to use about 90% of the time. So you can go ahead and open it.
So again, you're not using...
This is where I pretend to look at the box. Good.
So again, for that version, you're using more of those anatomic landmarks in your x-rays rather than patient positioning, attempting to get horizontal with the floor, or anything like that.
Correct, yeah, and I think that those types of landmarks are the patient positioning and what corner of the room you're pointing at are fairly unreliable.
And so will you ream up now to 52, or do you stay 1 under reaming even for that actual implant?
Right, I stay under ream, so we'll go ahead and put the cup in.
Can you just show us the cup before you put it in?
Of course. Excellent. So this is the R3 cup. This is a solid cup. You see the locking mechanism is down on the cup, not by the locking mechanism where it tends to be a little thinner and more likely to fatigue or to fracture from impingement. And you see this, cutout right here. I'll put it in an accessible spot if I ever need to remove the poly. This is where the tool goes to take it out. And the stick-tight coating, I'm sure you guys have heard all about. Has probably and someone correct me if I'm wrong, I think it has the
coefficient of friction.
The highest friction. Yeah, exactly. Okay.
With that stick tight and that high coefficient of friction, do you use any special mallet or anything to get this cup to go down?
No, this is a regular mallet. Good. And we rock the whole pelvis here. Probably a little bit more closed than even my trial was, but I like the anteversion as well, so I'm pretty happy with that.
And given that your position looks like it's changed slightly from your trial, how can you assure that you're all the way down?
Well, I'll take the center out. I have that cut out, and you kind of just get used to that, but I can see that I'm flush with the bottom there.
Great.
And I need to cover it for a second here. Okay. Water.
So one of the benefits of the R3 is the modularity of the liner. Have you ever put in any of the alternative bearing surfaces?
I think a few years ago I used a few metal liners, but for the most part I'm putting in just plastic these days. And this is an XLPE liner. I use a cross-linked liner on all my cases.
And so that obviously looks like
What I like about this system,
so that looks like the final,
Yeah,
the final implant. You don't use any trials, and it looks neutral.
correct. I use a neutral liner, and it's a 36 inner diameter.
How did you choose which
That
head
looks good.
size
And what
to
I
go
like
with?
about this system is that when I get up to 52, I like to go to the 36. I like at least 5.8 or 5.9 of polyethylene. Can I have a curved osteotome, please?
So will you always put in the largest head that the cup will allow?
No. In fact, I use the 36 on just about all my cases. I am not comfortable using the 40 or the 44 at this point. That introduces another taper. All right, good. Good. All right, let's move this back. Can I have a Ticron? Good. Now I'll show you. We go ahead and tag the. I go ahead and tag the capsule pickups. You can see when I pick up the top corner of that capsule, the piriformis is right here, still attached, so I don't have to go digging around for it. This feels like number 5.
So which suture is that are you using?
This is a non-absorbable polyester suture, Ticron or Ethibond, but this one happens to be Ticron. I usually use a number 2, but I think we have number 5 with us today. So I'm just tagging the inferior corner that I made. I'll just take these out of the way. Good. Okay. What's that? I'll take the Charlie out at this point. Let the skin rest a little. And now okay, let me have the Johnny Holmes. Oops. Okay, go ahead and hold that pretty please. Now put this behind the lesser troch, behind the psoas tendon. Stays hooked in there. This goes over the... And then this is the Smith & Nephew Homan. I got tired of saying that, so I just call this the Smoman. Good. And then this, we're just going to move a little bit like that. Perfect. So can you guys all see the femur?
Yes, excellent view.
Pretty good.
So any tips or tricks for preparing the proximal femur and opening the canal, particularly with the SMF?
Yes. With the SMF compared to the other stems, I mean, I think it's important to get out lateral. Let me have the weapon and show you what I mean. So I use this. I don't know, can you guys see this? This I stole from a striker set, and this is just what I used in fellowship, and this is what I'm comfortable with. Anything will work as long as you're able to get lateral enough, but this is just what I happen to be comfortable with. So we have a few left over, so I use this. Now I start this like a piriformis nail, so just in front of the piriformis fossa, and I'll let it find the canal. And then again, this is very, very important to get lateral, so I spend a lot of time. Yep, good. You know what, maybe back to the other camera view. I got this, yeah. So now I have it in the canal. I'll spend a lot of time getting rid of that lateral neck. I want to be flush with the trochanter into the cancellous bone just a touch. It's very, very important to get lateral here so you don't get hung up, number 1. And number 2, we get a good valgus position on the stem. Okay. Let me see the sucker here. So then I'll check, and I can run the sucker right up the lateral cortex, and there's no step off. It doesn't jump out. There's no lateral neck there left at all. So protecting the abductor here, which is very important. and we don't want that to get too beat up. And I think we're out.